So, good morning, good evening, good afternoon to everyone around the world, and welcome to our ACNS ISMINS webinars. Today, our chair is Professor Esmin, who is the head and senior consultant neurosurgeon of the Department of Neurosurgery, Tunku, and at the Hospital of Kuala Lumpur, and Department of Pediatric Neurosurgery, Hospital Tunku, Asias, Women and Children Hospital in Kuala Lumpur. He's also the head of Neurological Service and Ministry of Health in Malaysia. So our first speakers of today is Professor Gota Nagayama, who is the consultant neurosurgeon of the Department of Neurosurgery of the Jikei University School of Medicine in Japan. His topic today is current status of bypass surgery. Our second speaker today is Professor Avelino Parajon. He's a head spine section, Department of Neurosurgery of the Hospital Universitario Ramón, Cajal in Madrid, Spain. He's also the head of neurosurgery of the Med Center in Madrid, in Spain. He's the president of Sociedad Española Circular and Invasive de Columna, ACNISMINS. He's also the president of International Society for the Advancement of Spinal Surgery, and is also a director of a European course minimally invasive spinal surgery. He's also the director of a Latin American course of minimally invasive spinal surgery. Today, his topic is the evolution of the lateral transpsoas approach to the lumbar spine. And our discussion today, we have Professor Ajit, who is the senior consultant and the head of the Department of Neurosurgery in KIMS Hospital in India. Our second discussion is Professor Ezra, who is the chief of the Neurovascular and Vascular Therapy Center, Department of Neurosurgery, Faculty of Medicine, Universitario, and in Indonesia. So to moderate a session with me, we have Dr. Atik and Hui, and also Biswas. So without further delay, shall I hand over the podium to our chair, Professor Esmin?
Thank you very much, Ben. Good morning, good afternoon, everyone. It is my privilege to chair this ACNS Joint ISMINS webinar session. So as mentioned earlier, we have two speakers. So the first speaker, we talk about the current status of cerebral bypass surgery. And we know that for a seasoned neurosurgeon, bypass surgery still is one of the most complex procedures, especially for the young neurosurgeon. So currently it's involved from primary ischemic stroke treatment to specialized technique for complex neurovascular condition like moya-moya disease and skull base tumor. So we also know that the indication has been expanded beyond neurovascularization for stroke, but also increasingly used to protect the brain during the management of complex aneurysm, skull base tumor, and vascular malformation. So a lot of new technological advancement being used, especially the use of intraoperative flow monitoring like ICG, which is currently essential to confirm the graft patency and the measurement of blood flow during and after the bypass. We also use a flow regulated bypass, which help to optimize the cut flow index to prevent the complication. And there are also shift in technique from EC-IC bypass, and nowadays a growing interest to do intracranial bypass for using a shorter graft and improving hemodynamic matches. So there are also refined technique in terms of specialized disease like moya-moya. And nowadays we know that the bypass is being less performed because of the development of endovascular. But we must understand that there are certain diseases remain, for example, moya-moya, where bypass is deemed necessary. So therefore, nowadays a lot of new technique, including using of simulation for providing training, especially for young neurosurgeon, because the numbers of the bypass surgery has been reduced, but yet we need to make sure that our young generation and future surgeon have the ability to perform bypass. So it is my privilege to introduce the first speaker of this session, Professor Gota Nagayama, who is a consultant neurosurgeon at Department of Neurosurgery, Jikei University School of Medicine, Japan. So he will talk about the current status of bypass surgery. Professor Gota.
Thank you.
Yes.
Thank you for inviting me to such a wonderful conference. Thank you for Professor Kato, Professor Azumi, Professor Ben. Today, I would like to talk about the current status of bypass surgery at our hospital. At our hospital, bypass surgery is primarily indicated for atherosclerotic lesions and Moyamoya disease. STMCA bypass remains a fundamental basic procedure, and ensuring its reliable execution is important. Additionally, we sometimes perform it as an emergency rescue procedure or for complex aneurysms. Here is an actual pediatric Moyamoya case example. A 10-year-old girl with a family history of Moyamoya disease, whose older sister died from cerebral hemorrhage due to the same Moyamoya condition. She has recently begun experiencing the TIA symptom. Resting state imaging revealed decreased blood flow in the right cerebral hemisphere and significant reduction in reserve capacity following IMP loading. Given the patient's symptomatic severe hypoperfusion, surgery was planned. DSA demonstrated reduced blood flow around the motor area, leading to the decision to perform a target bypass procedure in this area. Direct bypass is the same as for atherosclerosis lesion, anesthesia STA and M4. However, we should be careful as Moyamoya patients' vessels are very thin and fragile. In addition to that, it also has an indirect bypass, placing blood-flowing tissues such as dura mater, periosteum, muscles, and arteries on the surface of the brain may increase blood flow. It is said to be effective in almost all pediatric and half of adult patients. There are various techniques for this indirect bypass, and which one to use depends on the facility and the operator. I try to use every tissue possible to increase blood flow a little bit. It's called EDMAPS. A feeling of parietal branch is done. The direct bypass itself is the same as in the case of atherosclerotic lesions. But in the case of Moyamoya disease, the M4 may be quite fragile, so it is sutured more gently. Located M4 never heading towards the motor area and carefully suture with aim to eversion. Following that, an indirect bypass was performed and the surgery was completed. The bypass patency was good, and the TIA has resolved. Okay, this is IVDSA. Today I don't have much time, so I will talk about it very short. But this IVDSA can make the very easy to check the patent. Next is bypass surgery for aneurysm treatment. I perform being both direct and endovascular surgery. So every time I think about which is better for patient for this aneurysm, I think the following situations are considered when using a bypass. Initially, branches were created from the dome, but bypassing this step has become less common nowadays because of development of endovascular treatment. Even in aneurysms where the pica clearly arise from the dome, coiling can be performed while preserving the pica by herniating technique with the stent. Even in complex aneurysms involving the SCA, it is possible to coil while protecting the SCA with a stent. I believe that with the advancement of endovascular treatment, OA pica and SCA bypass have decreased significantly. The same applies to large and giant aneurysms. This was a giant internal carotid artery aneurysms from 9 or 10 years ago. At that time, we performed a high flow bypass. In such cases, the initial internal carotid artery must be completely blocked, so a longer, larger blood vessel must be used as a bypass. Therefore, the radial artery is used after peeling off the STA and create a pathway for the radial graft. After dissecting the sylvian fissure, we identify the M2 that performs the anastomosis. And then identify the M4 that is distal to it. The STA was anastomosis to M4 first, and the RA anastomosis to M2. And the RA was also anastomosis to the ECA. And the ICA was trapped. After surgery, the aneurysm was confirmed to be occluded. The patient was discharged with no deficit. However, with the advent of flow diverter, high flow bypass is rarely performed in such cases anymore. In this case, we simply deploy flow diverter only. Operating time was only 30 minutes. After just 6 months, the aneurysm had almost completely disappeared. The progress in endovascular treatment is truly remarkable. Even though there are still a few cases where bypass surgery is necessary, this includes the following situations. For example, consider a case of a bacterial aneurysm with this peripheral microaneurysm. Clipping is not feasible. Furthermore, I believe endovascular treatment can only achieve the occlusion of the parent artery. In such case, bypass surgery is still necessary. I dissect the posterior interhemispheric fissure, and this is a bacterial aneurysm. First, we attempt the side-to-side A3 bypass. That bacterial mass emerged, leading us to like this, leading us to conclude bypassing here was impossible. And therefore, we avoided this site and performed the side-to-end A3 bypass. And we then trapped the aneurysm and concluded the procedure. And this case involved recurrent aneurysm following stent-assist coil embolization. With partial thrombosis present, I believe such aneurysm are difficult to cure definitively with endovascular treatment. In this case, the plan was to perform an OA P3 bypass and occlude P1 like this. I harvest the OA, dissect the posterior. After that, dissect the posterior interhemispheric fissure, secure the P3, and anastomosis bypass here. Then, due to the flow dynamics, the aneurysm had disappeared the next day. It's been 6 years now, and there has been no recanalization. As I have been saying, advance in the vascular treatment have made it possible to resolve many aneurysms using this approach. However, I still feel the direct surgical procedure like bypass surgery remains necessary techniques. This is a case where recanalization could not be achieved with ICAD during thrombosis retrieval. Sorry. A thrombectomy was performed as usual using combined technique. It recognized once, but due to atherosclerosis, it quickly reoccurs again. Currently, there are no effective stents available for use in regions that become occluded due to such atherosclerosis lesion. And therefore, we performed an emergency bypass in this case. And this patient is doing well thanks to the bypass. I still believe bypass surgery is a necessary and vital basic procedure, even in the context of rescue purpose. Yeah, in conclusion, I discussed the current status of bypass surgery at our hospital. Bypass surgery is an essential surgical procedure for conditions such as atherosclerosis and Moyama disease, as well as for emergency rescue purpose. The development of endovascular treatments has been rapid, but I believe that situations requiring bypass surgery will inevitably arise in aneurysm surgery going forward. Thank you for your attention.
Thank you very much, Professor Nagayama. It was a very nice and a comprehensive presentation. So before I open the discussion to the rest, I have two questions. Number one, your experience in doing a salvage surgery after failure endovascular treatment for aneurysm. So for example, you have a huge aneurysm and they put a flow diverter but it's failed and you have a stent in situ. So what would be your strategy, and is there any challenges compared to you do bypass straight away without the stent in situ?
First, maybe first I think the endovascular first, because skull base and the fusion aneurysms for like disease, the operation the surgery is very complex and have a high risk for the patient. So first, I try to plan to use endovascular. But sometimes endovascular, of course, endovascular cannot treat the such as complex disease. So bypass surgery is still necessary, I think so.
今の質問は、最初にエンドバスクラーでやってうまくいかなかった場合はどうするかと、
ごめんなさい。
ことを聞いていますね。
すみません。
もう中にステントが入っちゃってる場合ね、FD とか。
すみません。Sometimes next adding the stent like a flow diverter can treat the huge aneurysm. But of course, some aneurysm cannot be treated with only endovascular. That time, I try to do direct surgery. But of course, we must think about the stent inside the parent artery. So we must plan to think location of a trap parent artery.
Okay, thank you. I think I've seen a lot of questions from the panel as well as from the chat. So maybe we open to them for a question, please. So Biswas?
Yeah. Hello, sir. Thank you for the opportunity. Hello, Sensei. It was an excellent presentation. I rather have a couple of questions regarding the Moyamoya disease. Sir, in case of pediatric age, do you evaluate stage by digital subtraction angiography in pediatric age, especially if the age is 2, 3, or 4 years of age?
Only for baby,
Yes.
only we use only MRI.
Up to how much the age of the baby?
Of course, maybe until 7, 8 years old.
7 or 8 years old. Okay. And second question is, do we do perfusion image in all cases of Moyamoya disease?
No, for baby, we don't use.
Or in which specific case you would like to consider perfusion image? I mean, any relation to stage Suzuki grading?
Yeah. But so we cannot know the correct stage But we judge the indication of operation for with symptom and MRI.
Okay. Next question is, if bilateral Moyamoya disease you have done direct or indirect bypass bilaterally, do you still continue the ecosprin and antiplatelet drug for this patient?
Sorry, pardon.
I mean,
After
continuation of the antiplatelet regimen for patient underwent bypass surgery in Moyamoya
for
patient.
Moyamoya patient, I don't use antiplatelet drug.
Okay. Okay. And last question, sir, you have mentioned endovascularly treated failed case or recurrent case where you have done surgery. I would like to know if there is role of second time endovascular treatment, especially in posterior circulation. We can do flow diverter if simple coiling doesn't occlude the aneurysm. In those cases, how do you take decision for bypass or endovascular treatment?
Such in that case, in Japan, flow diverter is not available.
Okay.
So
Okay.
I think that procedure is maybe better.
Okay. Okay. Thank you, sir. Thank you so
Okay,
much.
thank you,
Thank you.
Biswas. So I would like to
Thank you.
take a few questions from the chat first. So I think we have 3 questions. The first question from Dr. Ude Bharti. So pertaining to one of the case that you show, what was the follow-up of Moya of the girl after bypass? Did her TIAs resolve?
Yeah.
So the TIA resolved.
Pardon?
前々のオープンの後に TIA はなくなりましたか？
Yeah, yes.
Okay, all right. Thank you. So second question from Meda Bias. So what is the rate of recurrence of aneurysm after endovascular treatment in your practice?
Sorry. After?
I think the question is a little bit away from the bypass. She asking about the rate of recurrence of aneurysm after endovascular treatment. Do you have experience on that?
Yeah, I have maybe only about 10 case, 819.
何%ぐらいですか？サイズとかによって違いますよね。
そうですね。Yeah, 2, 1 or 2%.
どのぐらいのサイズだったら 100% OK ですか？
エンドバスキュラー。
どのぐらいのサイズがエンドバスキュラーで、どのぐらいのサイズだったら 100%OK で、これ以上になると。
前方循環だったら10ミリ以下は多分 100%。後方循環がやっぱり難しい。Bifurcation type aneurysm is difficult with endovascular.
Okay. So there's another question from Dr. Bharti also. What about bilateral Moya with aneurysm? What would be your treatment approach?
But, Moya?
Yeah, bilateral Moya with aneurysm.
前のに動脈瘤が合併したものをどうしてますか？
I have never experienced such case. But maybe in posterior circulation, I will try to perform with the endovascular first. And after that, I will perform the STMC bypass plus EDOMAPS.
If you have bilateral Moya, do you treat one after another, or how do you decide?
the side of symptom side, hemorrhage or ischemic.
Okay, all right. So maybe question from Ben. Ben, you raise your hand.
Yes, and a very short question. Thank you, Professor Nagayama, for your presentation. I would like to ask about for those giant aneurysm, if they have mass effect, and for example, affecting the vision or some cranial nerves, would you do endovascular treatment or you do the hypo bypass?
Yeah. That is a very difficult problem. Sometimes endovascular can treat the symptom, but sometimes cannot treat symptom. So maybe depends on the patient condition and yeah. I think so.
I see.
I think the location of the, especially the posterior foci, is very difficult. Giant partially thrombosed one. Usually we can use the FD.
I understand. Thank you so much, Professor Nagayama, Professor Kato. Thank you so much.
Is there any more question from the panelists for Professor Nagayama? So if not, I think we shall move to the second presentation. So it is my privilege to introduce Professor Avelino Parajon. He's the head spine section from Department of Neurosurgery, Hospital University Ramón y Cajal, Madrid, Spain. So he will talk about the evolution of lateral transpsoas approach to the lumbar spine. Professor Avelino, you may start your presentation.
So thank you very much for the invitation. Thank you very much to Professor Yoko Kato, Professor Admi Elias, Professor Ben and the ASEAN Congress of Neurosurgeons and the ISMINS. It's a great pleasure to be here and to share my ideas and our experience in the lateral transpsoas approach to the lumbar spine. So these are the disclosures. So we all know the advantages of interbody lumbar interbody fusion. So we know that we can increase fusion rates, improve sagittal balance, and improve indirect decompression. So there are nowadays different alternatives for a spine surgeon to perform this type of lumbar interbody fusion. And the lumbar lateral interbody fusion is a relatively new technique. So it comes from the beginning of the century. And it implies the knowledge of a new surgical anatomy, because most of spine surgeons were used to do posterior approaches, and now we have to deal with a new vascular and even neural and visceral anatomy. LLIF or transpsoas surgery has some advantages. So it's very good for coronal balance correction, for indirect decompression. It's good for increasing of lordosis. Also increases the fusion rates compared to some other minimal invasive techniques. It can decrease the number of fuse levels due to its ability to correct the coronal balance in deformities. It helps us to minimize the number of levels to be fused, and of course has the advantages of other minimal invasive techniques like less blood loss, less hospital stays, and in general less complications than open surgeries. In the early days of the techniques, surgeons like me, we learned this technique through workshops organized by different implant companies. But nowadays, within the EOSpine MIS task force, we have tried to systematize the technique into standardized steps that are independent of the type of implants surgeons use. We believe that this approach can facilitate learning, can promote the wider adoption of the technique, and also support its use in scientific publications. So we think the instruments we need for the procedures are this on the slide, the radiolucent table, because it's a X-ray dependent technique. We need a dilator set, table mounted retractor, fiber optic light source, of course, discectomy set instruments, osteotomes, and so forth, and of course, the implant set. Main indications are lumbar spondylolisthesis, adjacent level disease. I would say is probably one of the best indications, especially in the early phase of the adoption of the technique. Adult deformity, this is a little bit more challenging, but it's definitely very good technique for adult deformity correction. And of course, any type of lumbar stenosis with instability. There are some contraindications, especially severe osteoporosis, intracanal fragments, and previous abdominal surgery. And the L5S1 level is not a good level for this technique. Probably ALIF would be much better. Some previously commented contraindications we know that are not strictly contraindications, like the lock facets. So in some cases we can even perform that. And also if some anatomy is favorable, we can even do in L5S1, like in this case, but probably now what we're doing here is a lateral ALIF, or a pure anterior ALIF is much better. So the phases in the surgery would be the patient positioning or setup, X-ray confirmation, incision localization, muscular dissection, neuromonitoring, dilators and retractor insertion, disc preparation, implant insertion, additional fixation, and closure. So we will go very quickly through these phases. So patient positioning in lateral, pure lateral position with the legs flexed to relax the muscle, contrary to the Psoas approach, in which approach we prefer to have the straight legs to have the psoas muscle constrained, but in this case, and for the transpsoas, we want the legs to be flexed. Then we do a X-ray confirmation or pure orthogonal AP and lateral projections. Sometimes positioning of the patient and X-ray confirmation will take even more time than the strictly surgical steps, but we have to explain to all the team in the OR, like the anesthesiologists, nurses, and so forth, that this is essential. It's crucial to have a very good orthogonal views to avoid complications. Incision location, we do it with X-rays, of course. In some cases in which we combine navigation and X-rays, because we are doing, for example, also particular percutaneous screws with navigation, we can use navigation also to confirm the position, but definitely X-rays are mandatory because there are a lot of surgical steps in which we will need fluoroscopy confirmation. Muscular dissection, we have to identify these three layers, the external oblique, internal oblique, and transverse. And if the surgeons can clearly identify these three layers, is very, very easy and very difficult to get lost into the dissection. Neuromonitoring, I would say, is not mandatory, but is highly recommended to prevent neural damage, especially in the lower levels, L4, L5, and L3, L4. And I will say that an experienced neurophysiology team is crucial in achieving good outcomes. Now we routinely use local nerve mapping. We use free EMG, continuous monitoring. We use transcranial evoke motor and somatosensory evoke potential. Phase 6 will be sequential dilators and retractor insertion. Then we have to do a thorough discectomy. With this lateral anterior approach, we are able to do a very good discectomy compared to posterior PLIF or MIS TLIF techniques. It's essential to do a very good end plate preparation, but not work too hard on the end plates in poor quality bone or in elderly patients. And then implant selections, we have different cages like PEEK, PEG, titanium. We have expandable cages. We can discuss about the advantages and disadvantages of all these different implant cages. I would say that in scoliosis and spondylolisthesis, posterior pedicular screws definitely are needed. In some adjacent level disease, that the one we can see on the left side of the slide, maybe just a plate is enough. Some surgeons like to do standalone cages. I would not recommend it for multi-level, for spondylolisthesis, or for deformity patients because it has a risk of subsidence and mobilization. Closure of the fascia is essential to prevent muscle herniation. I would say that most of the complications and challenges can be avoided using a meticulous technique and good neuromonitoring, as you can see in this table. So definitely LLIF or transverse approach is a very versatile technique that can be used in very simple, straightforward cases like this degenerative case. But also we have expanded the indications for some complex cases like this L1, L2 chordomas. Lateral transpsoas approach is a good tool to perform lateral corpectomies in the mid lumbar spine. The most frequent complications in the transpsoas approach are sensitive neurological. Most of them are transient, and also the anterior tight numbness and a little bit of transient loss of strength for the anterior flexion of the or extension of the hip, and this is due to the manipulation of the psoas muscle, and of course most of the times it's transitory, it's transient. Subsidence and pseudoarthrosis can also occur, especially if no additional fixation is used or in poor bone quality patients. Some surgeons have moved from pure lateral transpsoas to press-psoas approach because of those neurological complications, but this can increase the risk of vascular complications. Some tips to avoid some of the most frequent complications, I would say, we have learned through the years are to minimize the retractor opening time, the use of neuromonitoring again, and a careful dissection. Also, a meticulous preoperative planning through a whole X-rays studies and meticulous planification of the levels to be treated is very good to avoid complications, like in many other surgical interventions. So this is a typical case with a 75-year-old patient with severe back pain and neurological claudication. The patient has adult deformity with lumbar stenosis, and we performed two step surgeries. We perform lateral cages in the first day, and some days later we put posterior screws, percutaneous screws, and in the upper part we did a hybrid technique. This is another case, a 76-year-old woman with 3-level stenosis and with severe low back pain and claudication. In this case, we did a one-day surgery, so we did in the same surgical day the cages and the pedicular screws. One very common problem that the spine surgeon face today is in the office, in our daily routine, is the adult deformity. We have this type of patients, like this 80-something-year-old patient that he asks for preserving the quality of life, and he has a very complex deformity. And we know that sagittal balance is a crucial factor related to disability, and of course classic osteotomies can achieve a very good sagittal balance, but we pay a high price for that, so we have a very lot of complications, and this is the typical patients we can do with open surgeries, with osteotomies and upper thoracic through the pelvis fixation, but we know that those patients need a lot of days in the hospital, 3 days of ICU, severe blood loss, and so forth. So some minimal invasive techniques like the transpsoas can help us in improving the sagittal balance in those patients. And so we have several strategies like lordotic cages, for example. Simple lordotic cages can improve 6 to 8 degrees per level. The next step will be the anterior column release. It's a more aggressive technique with better improving in lordosis. So we have this case, for example, in which we study each of the levels. We can do a 3-level anterior column release, and we put hyperlordotic cages, and we can have a very good correction of the lordosis. We know that with this anterior column release, we can achieve up to 17 degrees of segmental lordosis. So with the combination of hyperlordotic cages, anterior ligament release, spinal process, and facial resection, and posterior compression through the pedicle screws, we can gain up to 30 degrees. Expandable cages are a new promising technology that may help in gaining lordosis, so we can use it in some of these cases. The main problem we have, for example, in Spain is the price. The price of the implants are double the simple non-lordotic cages. So we have seen in the previous slides that many surgeries are done in stages in 2 different days with good surgical results, but this increases operative time, increases hospital stay of the patients, and of course, cost and even some complications. So the lateral single positions, and nowadays the prone single position is an alternative to do everything in one single day. And in those cases, we can avoid those complications. No? So this is a typical case of a lateral single position, combining lateral transpsoas approach for L3, L4, and psoas approach for L4, L5 with anterior column release and expandable cages. Navigation and robotics are very, very good tools to help in the position of the percutaneous screws in those cages that with x-rays I really found it very, very difficult with a high rate of malpositioning of the screws. This is the final results. So some tips that we have learned about the positioning of the cages with the time and then had been recently published is that a more anterior cage position helps in increasing the lordosis, while an excessive high cage can increase the risk of pseudoarthrosis. In contrast, a wider cage can help to maintain the decompression for a longer time and prevent subsidence. So my final tips to avoid complications in the transpsoas approach that we have seen through all these years is patient selection is essential, as in any other surgical technique. Preoperative planning, systematization of the technique, follow all the steps, intraoperative neuromonitoring, time, avoid more than 20 or 30 minutes with the retractor open. Don't break the table. This is something that we used to do in the first days, and we have learned that this can increase the risk of having neuropraxia, so we don't do it anymore. Don't use monopolar bobby for the muscle dissection because we have some sensory nerves that we can damage in the soft tissue. Avoid biloising of the end plates, especially in poor bone quality, and the cages better wider than too high. The final tip will be that there's no ideal technique for every case patient, so tailored surgeries is what we have to do. So definitely, spine surgeons have to learn every technique and master it. And thank you again very much for your kind invitation to be in this meeting.
Thank you very much, Professor Avelino Parajon. So again, it was a very good lecture. So I have a couple of questions. So recently, people moving away from lateral transpsoas to prone position. So do you have any experience? Can you comment on the advantage of prone to lateral decubitus?
Well, in multi-level surgeries, prone position, single prone position can be better for lordosis. So I would not recommend to do a lateral single position in more than 2 levels because then it can affect the lordosis. So prone is better. Prone position needs some special tools because when you're hammering, you can move the patient. So you need some special retractors to hold the patients. But many companies provide them. And also now we are having more and more obese patients in Spain, same as in USA, no? Because of we lost the typical diet. And can be a problem if you don't have an adequate table because you need a table where you can put the belly of the patient and fall down but it's a good alternative. I have to say that I don't have a lot of experience in the prone position. We are just starting with that technique. We have a lot of experience with the lateral and with the two stages, but that's my personal experience.
Thank you. So my second question is to avoid complication, especially to the injury to the lumbar plexus. So what is your tips and tricks and how we can avoid it, especially does the utilization of intraoperative neurophysiological monitoring really play a role in this?
Yeah, I would say there are two tips. One is study the preoperative MRI and to see if you can identify the lumbar plexus, and then in some cases maybe you have to move to psoas and L4, L5, for example, if you don't see clearly where you can find the plexus. And definitely, I would say in our case, neurophysiology is mandatory. We have a very, very good team of neurophysiologists, and they have learned with us through all these years. And I think I will, in some courses, I have seen surgeons that say, well, I don't need neurophysiology. I will not recommend to do it.
Thank you for your advice. So Ajit, you have a question?
Yeah. Regarding it's a very good overview. So my question is regarding some basic facts that usually the degenerative disc disease affect L5, S1 and L4-5, lower spinal lordosis area. So majority of areas where we have to act is L4, L5 and L5, S1 and maybe above depending on the classification. So this X-leaf usually difficult in L5, S1 and L4, L5 level. That is one of my question. Second, always you have to do a second surgery. You put a cage one day and fixation next day. So this can be very well overcome by T-leaf. Now T-leaf. Now we have expandable cages that we can use for T-leaf. So these cages can expand and they can create 6 to 7 degree at each vertebral level. So this can very well reconstitute our spinopelvic balance, global balance, as well as the spinal balance. So what is your comment on comparison between T-leaf and X-leaf in this aspect?
I'm a big fan of MIS T-leaf. I love it. It's a technique that I do very frequently. Yes, you're right, of course. I would say that definitely L5S1 is not the indication for for lateral transpsoas. In this case, A-leaf probably is the best technique, or T-leaf is a very good alternative. I will say that for L4, L5, transpsoas or psoas are the two best techniques. And transpsoas, I will say, is a very, very good technique for L3, L4, especially for adjacent level disease. Those cases you have a posterior fixation 4-5-1, and you need, because you have a listhesis and stenosis in the upper level in 3-4, that's the perfect case for a transpsoas approach. So lower rate of neurological complications, very good anatomy because you don't have the ribs and you don't have the iliac crest bothering you, so that's the perfect indication. Yes, expandable cases for MIS T-leaf, I think they are very good in helping to provide lordosis. If lordosis is the main objective in L5S1, probably neither T-leaf or MIS T-leaf or transpsoas is a good technique. A-leaf would be better, or even an open posterior T-leaf is also a good alternative, yes.
Can I ask one more question?
Yes,
Of
please.
course.
Please.
Yeah. My question is, do you measure this spinal lordosis, pelvic tilt, sacral slope, global balance, such all these parameters before surgery? And does these parameters have any role in our surgical planning? What is your...
Yeah, I think that this is something that we neurosurgeons have learned from our orthopedic colleagues, and we are doing now in our routinely practice. And I think that's essential. Even in a one single level fusion or two level fusion, we have to study the preoperative Russell type and all the sagittal parameters, because otherwise we can have a very nice decompression and a very good screws in place and cage in place and a very terrible sagittal balance, and this will bring adjacent level disease and back pain and so forth. So you're right, this is very crucial to do a very good preoperative study of all these parameters.
Yeah, so this type of cases, it is better to assess all these parameters and to assess how much angulation should be given in the lower lumbar level. You have to do all this. That is your advice regarding this. Okay. Thank you.
I have a question again. So in your experience, what are the most feared complication, or you have a complication probably if you want to share what you learned from that?
Well, I would say that the most frequent complications are neurological complications, especially at the level L4, L5. And the best tip is pay attention to what the neurophysiologist said. I have seen sometimes the neurophysiologist is saying, take care, you are too close to the nerve, and some surgeon says, well, it doesn't matter, and that's terrible. That's the worst thing you can do.
Okay, we have a comment by Dr. Uday Bharti. If you can open the chat box. So I just read, and probably if you like to respond. So written as I've done a couple of transpsoas approach, minimally invasive for fracture from D12, L4, L5 was a little bit difficult with good outcome. Excellent coronal correction with this height correction. With post pre-cut fixation and muscle disruption is more in MIST leaf. So you want to comment on that?
Well, I think that lateral transpsoas approach and even in the thoracolumbar junction is a good tool even to do a corpectomy for this type of fractures. I think this is technically demanding because in the thoracolumbar junction and in the thoracic, and then you can do through the ribs, or sometimes you can even cut part of the rib, and you have to go retropleural, and at this point definitely these cases are not for the beginning of the learning course. This shows that this surgeon has a lot of experience, but of course it's a nice technique, and I'm not sure if it damages the muscle less than the MIS T-leaf. For example, obviously when you introduce the tube to do the T-leaf part, obviously you can damage the multifidus a little bit more than when you do a transpsoas, of course. But I think also MIS T-leaf is a very good technique, as Dr. Ajit commented before.
Thank you very much. So do we have any more questions from the panel?
Okay, ask me. I have one question.
Yes, please.
Yes, I'm sorry, I just lost my connection before. So, yes, just one basic question, I think. Very nice presentation, but we need to know, maybe in your experience, what is the absolute contraindication and maybe a relative contraindication using this approach for spinal lesion? Thank you.
Well, I would say definite contraindication will be a severe osteoporosis, definitely. Some cases of previous abdominal surgery in the retroperitoneum, like kidney surgery in the same site or something like that, I will say that's not a good indication. And sometimes in the preoperative MRI, you can see those big, like Mickey Mouse called psoas, or you clearly see you have the nerves packed in your way. In those cases, probably you need to go for a posterior approach.
Okay, thank you.
Thank you, Asra. So I think if no further questions, I would like to thank both speakers, Professor Gota Nagayama and Professor Avelino Parajon, for a very engaging discussion and very excellent presentation, at least from my perspective. So I would like to pass over back to Ben. Maybe you want to have a conclusion, and Professor Yoko Kato too.
Yes, thank you so much, Professor Smith. Professor Kato, any comment from you?
Yeah, thank you very much, Paul. So first of all, I thank you very much, Avelino. So nice to see you again, because I knew him. I met him in Vietnam, Dana Congress. Thank you very much for your support for Avelino.
Thank you.
So I think Nagayama Sensei, his presentation is very, very important, especially for young doctors. Ones who want to do the open surgery, it's very important technique. Not only the STMC, but also when you tear the vessels, immediately you should such kind of technique. If you have, I think that you can rescue the patient, I think. So that means is vascular surgery technique is, of course, maybe European doctors know more, I think, in their surgical field, but I think in Japan, still we need very, very important technique. Thank you very much. And also the Avelino, thank you so much for your 2 years here, nice experience. So I think minimally invasive, the full point is your techniques, you should please continue and extend in the future. Thank you so much. It was excellent, the 2 talks. Ben, Sensei.
Professor Kato. And also, on behalf of the Educational Committee of ACNS, I would like to thank Professor Smith for chairing this great section, and also Professor Nagayama and Professor Avelino for accepting our invitation to this ACNS ISMINS webinars. Today we have a very excellent lectures, very fruitful discussion. So it's time to say goodbye to all of us, and I have to see you next webinar. Thank you so much for joining today.
Thank you
So much.
Thank you so much. This was all the best.
Yeah.
This was